Usually when we study medicine, the entire framework is built around restoring homeostasis.
Right. Yeah. Fixing things.
Exactly.
Yeah.
Like you're setting a fracture or you're prescribing an antimicrobial to clear up an infection or correcting a metabolic imbalance. It's always about returning physiological systems back to their normal baseline.
Yeah.
But the moment you cross the threshold into veterinary anesthesia, that entire paradigm completely inverts.
It really does.
Yeah.
Because you're stepping into this realm of controlled, intentional physiological suppression, which is wild when you think about it.
It is.
You literally take a patient's central nervous system, their cardiovascular drive, respiratory function, and you push them right to the absolute brink of failure. And then, and this is the hard part, you just hold them suspended there.
Wow, yeah.
It's this profound manipulation of physiology. It requires a constant, hypervigilant balancing act to, prevent that suspension from becoming a total collapse.
Well, on that intense note, welcome to this deep dive. And this one is custom tailored for you, the veterinary student currently staring down, let's be honest, a massive stack of clinical pharmacology notes.
A very intimidating stack, I'm sure.
Definitely. So today, we're taking those notes, pulling out the absolute core fundamentals, and decoding the clinical, anatomical, and sometimes hidden genetic booby traps that are just waiting for you on the surgery table.
Because the objective here goes way beyond just passing a board exam. We're talking about the mechanisms that will literally drive your life and death decision-making in the clinic.
Exactly.
We have to move past just, memorizing protocols and really establish the underlying pharmacodynamics and the physiological realities of these patients you'll be managing.
Because when you have a tachycardic patient on the table, you can't just pause the surgery to flip through a textbook.
No, absolutely not.
You have to understand the why behind the what's. So let's start right at the foundation. Before we can even begin to anticipate what might go wrong, we had to define what going right actually looks like. The physiological targets of a successful procedure. And your clinical notes anchor everything on this one concept, the anesthesia triad.
Right. The triad. These are the three non-negotiable targets for general anesthesia. You've got analgesia, narcosis, and muscle relaxation.
Okay.
And if you are lacking in any one of these areas, the surgical environment is just inherently unsafe. Let's look at that first pillar, analgesia. As a clinician, you obviously know this is about blunting nociception pain relief, but its role during unconsciousness is purely physiological.
And wait, this is a crucial distinction, I think, because we aren't just preventing the conscious perception of suffering.
Yeah.
Right? Because the animal is asleep. They're unconscious.
Exactly.
We're trying to block the autonomic nervous system's response to the surgical trauma.
Yeah, you hit the nail on the head. The nociceptive pathways, they don't just magically shut off because the cortex is asleep.
Right.
If a surgeon makes an abdominal incision without adequate analgesia on board, those pain signals travel right up the spinal cord and trigger this massive sympathetic surge.
Oh, wow.
Yeah, you will see a sudden, super dangerous spike in heart rate, profound hypertension, just a flood of catecholamines. So analgesia is completely mandatory to prevent that autonomic chaos from totally destabilizing your patient's cardiovascular system.
Okay, so pillar 1 is severing that nociceptive pathway. Pillar 2 is narcosis. And this is securing the central nervous system depression that you need for actual unconsciousness and amnesia, right?
Correct. You're shutting down the higher cortical center so the patient has zero awareness and zero memory of the event.
Which naturally leads us to the third pillar, muscle relaxation. And I'm guessing this is beyond just the obvious need to stop them from voluntarily moving on the table.
Oh, absolutely. We are really targeting the dampening of reflex arcs here. I mean, a surgeon cannot safely repair a complex orthopedic fracture or, ligate a tiny fragile vessel if the patient's skeletal muscles are tense or twitching or violently reacting to the stimulus.
So it's kind of like a three-legged stool. You remove one of those pillars, analgesia, narcosis, muscle relaxation, and the whole procedure just collapses.
That's a great way to look at it.
So how do we actually map the achievement of that triad onto the real-world chronological timeline of getting a patient from the prep room through the surgery and safely back to a kennel?
Well, your notes divide this process into 4 distinct pharmacological phases. We initiate with pre-medication.
Okay, pre-med.
And this isn't just about making the animal, easier to handle or less anxious. It's a highly strategic move to lower the sympathetic tone before we even induce them. By establishing this baseline of sedation and preemptive analgesia, we drastically reduce the required dose of the induction agents and the maintenance gases later on.
Oh, I see. So you're kind of lowering the ceiling of what you'll need later.
Exactly.
So after pre-medication, we hit induction. This is that acute transition phase, right?
Yeah.
Usually an injectable agent that rapidly crosses the blood-brain barrier to flip the switch from conscious to unconscious.
Followed immediately by maintenance. Here, you are just holding the line. The surgeon is working, and your sole focus is continuously delivering an anesthetic agent.
Usually a gas, right?
Yeah, typically a volatile gas like isoflurane or sevoflurane.
Mm-hmm.
And you're simultaneously monitoring their vitals to ensure you maintain that precise depth of unconsciousness.
And finally, we hit the recovery phase. The vaporizer is off, and the focus shifts to ensuring a smooth, gradual return of autonomic function and consciousness. The notes heavily emphasize preventing abrupt physiological swings here.
Because a smooth recovery is basically the ultimate test of how well you manage the first 3 phases.
Oh, really?
Yeah. If a patient wakes up thrashing, dysphoric, or they're instantly tachycardic, it usually means the nociceptive blockade, the analgesia, has worn off before the narcosis, which is a highly, highly dangerous state.
Okay, so this brings up a really obvious mechanical problem for me.
Lay it on me.
If we need to perfectly achieve all 3 pillars of that triad across those 4 chronological stages, relying on a single pharmacological agent seems, mathematically impossible without just killing the patient.
It is impossible. Volatile gases like isoflurane are excellent at maintaining narcosis, but they are incredibly poor analgesics.
Okay.
If you tried to achieve adequate pain control using only isoflurane, you would literally have to push the alveolar concentration so high that the resulting vasodilation and myocardial depression would cause fatal cardiovascular collapse.
Which introduces the core strategy of your clinical notes. Balanced anesthesia.
Yeah.
So we're utilizing a cocktail of different drug classes.
A very careful cocktail, yes.
Right. So we might use an alpha-2 agonist for sedation, propofol for induction, a pure mu agonist opioid for systemic analgesia, maybe a locoregional block with bupivacaine, and then we maintain the narcosis on a low concentration of isoflurane.
That's the recipe. This is polypharmacy utilized for highly specific synergistic effects. You are attacking the central nervous system from multiple different receptor sites simultaneously.
I want to push back on this a little bit, though.
Yeah.
Because looking at that list, alpha-2s, opioids, propofol, local anesthetics, volatile gases, it reads like a massive pharmacological burden.
It sounds like a lot.
Right. Doesn't layering 5 different classes of powerful central nervous system depressants massively increase the risk of adverse drug interactions? Aren't we just completely overloading the liver and kidneys?
It's a highly logical concern, but the pharmacodynamics actually work in our favor here through a concept called MSC reduction.
MSC reduction.
Yeah, lowering the minimum alveolar concentration of your inhalant. Let's look at the mechanism. When you administer a full mu opioid and you perform a locoregional nerve block, you completely interrupt the pain signal before it ever even reaches the dorsal horn of the spinal cord.
And because the signal never reaches the brain requires far less of the volatile gas to stay unaware of the procedure.
Precisely. Because you have effectively blocked the stimulus, you can dial your isoflurane vaporizer way, way down. You are using microdoses of multiple drugs to achieve specific targets rather than relying on one massive macro dose of a single drug.
That makes so much sense.
And the cardiovascular sparing effect of running isoflurane at, say, 1% instead of 2.5%, it far outweighs the metabolic burden of the opioid and the local block.
I like to picture it like a multi-factor digital security system. Instead of relying on one massive, heavy steel vault door, which takes huge energy to move and could literally crush someone if it fails, we use a thumbprint, a passcode, and a retina scan. Multiple distinct pathways working together, so no single pathway carries a dangerous load.
That's a perfect analogy, and that multi-factor approach directly dictates the safety of the recovery phase, too.
How so?
Because you use smaller doses of different drugs with varying half-lives, the effects wear off in a staggered, controlled manner. The isoflurane is exhaled quickly, restoring consciousness, but the locoregional block and the systemic opioid, they remain active for hours.
Ensuring they don't wake up in acute distress.
Yeah.
Okay, it's a really elegant system, but the notes make a very sharp pivot here.
Right into the danger zone.
Exactly. You can calculate the perfect receptor-targeted, balanced anesthetic protocol on paper, but the moment you administer it to an actual biological system, you enter that danger zone. The The patient's physical realities can completely upend your math.
They absolutely will. So we have to stratify patient risk. Your notes use the ASA physical status classification system to quantify this. A healthy patient with no systemic disease is an ASA 1. But when we look at patients classified as ASA 3 through 5, meaning they have severe life-threatening systemic disease, their risk of anesthetic-related death is 4.8 to 19 times higher than an ASA 1 or 2 patient.
19 times the risk. That is a staggering statistic.
It is.
And it's not just underlying disease, right? Urgency is a massive multiplier. Patients presenting for urgent or emergent procedures face a 13.6 times higher risk compared to routine elective surgeries. The whole system is just already in distress before you even administer a pre-med.
And we also see a profound age correlation. Patients aged 5 to 9 years old carry a 4.9 times increased risk. But once they cross that 9-year mark, the risk jumps to 12.8 times higher.
Because of natural geriatric decline.
Exactly. Reduced glomerular filtration rates in the kidneys, decreased hepatic blood flow. Their organs simply cannot clear the pharmacological burden at the expected rate.
But, looking at these risk multipliers, there is one data point in your notes that completely stood out to me. Mind-blowing, honestly.
I think I know which one you mean.
We always associate extreme conformation with risk, specifically brachycephalic dogs, like English bulldogs, short noses.
Right.
But the notes explicitly state that dolichocephalic breeds, the long-skulled dogs, carry a massive 3.7 times increased anesthetic risk. What is the actual mechanism driving that? Why does a long snout nearly quadruple the danger?
Yeah, the dolichocephalic multiplier is a striking data point because it directly contradicts our standard clinical assumptions. The mechanism here is twofold. First, dolichocephalic breeds often have an incredibly complex, high surface area nasal turbinate architecture.
Okay.
When you're using inhaled induction or maintenance agents, this massive surface area can significantly alter the gas dynamics and uptake rates compared to a normal mesocephalic dog, which leads to really rapid, unexpected shifts in anesthetic depth.
Oh, that makes sense anatomically. They just absorb it differently.
What is the second factor?
It's an issue of overlapping phenotypic traits. Many dolichocephalic dogs are also sighthounds, or they share genetic lineage with them.
Like greyhounds or whippets. Exactly. And these breeds have drastically different lean muscle to fat ratios compared to standard breeds. This alters the volume of distribution for highly lipophilic anesthetic drugs. So standard milligram per kilogram dosing charts can quickly result in relative overdoses or dangerously prolonged recoveries.
So the skull shape is essentially just a visible marker for a totally different internal pharmacokinetic environment.
That's a brilliant way to phrase it.
Which perfectly transitions into the next physical variable the notes highlight, thermoregulation. Heat loss seems to be a major, highly underappreciated danger.
It is a critical physiological failure under anesthesia. The drugs we use, particularly induction agents and inhalants, cause profound peripheral vasodilation. They open up the blood vessels right near the skin, completely overriding the body's natural vasoconstrictive mechanisms.
And in smaller patients with a high surface area to mass ratio, they just radiate their core body heat away incredibly rapidly.
Yes.
And as their core temperature drops, the metabolic rate drops.
Exactly. A hypothermic patient has depressed hepatic and renal enzyme activity. They process and clear the anesthetic agents significantly slower, plunging them into a dangerously deep plane of anesthesia, which leads to those extensively prolonged, super unpredictable recoveries.
We also have to account for obesity. You mentioned the volume of distribution earlier, and adipose tissue completely warps drug kinetics, right?
It really does. Many of our most common anesthetic agents, like propofol, are highly lipophilic. They love fat.
Okay.
In a highly obese patient, a massive percentage of that drug gets rapidly sequestered into the adipose tissue instead of remaining in the central compartment where it can actually act on the brain.
And adipose tissue has notoriously poor vascularity,
which creates a delayed release effect. The drug absorbs into the fat, pulling the patient out of a surgical plane way too quickly, but then, and this is the danger, it slowly leaches back into the bloodstream over hours,
causing severe respiratory depression long after the procedure is finished. So calculating dosages based on total body weight in an obese patient, rather than lean body mass, is a classic, often fatal, clinical error.
Absolutely.
So we have all these phenotypic variables, skull morphology, thermoregulatory capacity, body condition scores. But your clinical notes push even further.
Down to the DNA.
Right. As a clinician, you have to look past the physical conformation and anticipate the genotype. The notes outline this terrifying genetic minefield of breed-specific mutations that turn standard protocols into immediate crises.
We really must move away from the one-size-fits-all protocol. Let's expand on the brachycephalic breeds we touched on earlier. You are well aware of brachycephalic obstructive airway syndrome, or BOAS. The immediate concern is the anatomical airway obstruction. The elongated soft palate, averted laryngeal saccules, hypoplastic trachea.
But the notes stress that BOAS isn't just an airway issue. It's a multi-systemic physiological compromise.
Exactly. The chronic hypoxia and extreme inspiratory effort these dogs endure throughout their entire lives results in chronically high vagal tone.
Okay.
When you administer an opioid or manipulate their airway, that vagal tone can trigger sudden, severe bradycardia. Furthermore, the negative intrathoracic pressure they generate just to breathe often leads to secondary gastrointestinal issues, things like sliding hiatal hernias.
Meaning the moment they lose consciousness and their esophageal sphincter relaxes, they are at a massive risk for severe regurgitation and fatal pulmonary aspiration.
You cannot just intubate them and assume they are safe.
Wow.
Their recovery must be aggressively managed until they are sternal and actively rejecting the endotracheal tube.
Wow.
Now, returning to the sighthounds we mentioned, like greyhounds, the lack of adipose tissue is one issue, but the more profound danger is an enzymatic deficiency.
Yes, your notes point to a deficiency in the cytochrome P450 enzyme system. Walk us through the hepatic mechanism here.
Cytochrome P450 is a superfamily of hepatic enzymes responsible for the oxidative metabolism of many drugs. Greyhounds have a notable deficiency in specific CYP450 pathways, which severely impairs their ability to break down thiobarbiturates and other anesthetic agents.
Usually the primary action of a drug like thiopental is terminated by redistribution, right? It moves from the brain into the fat. But as we established, greyhounds don't have the fat reserves for redistribution.
So they're entirely reliant on hepatic metabolism to clear the drug from their system, and because they lack the required CYT450 enzymes, the drug just continues to circulate through the central nervous system. A standard induction dose that a Labrador would sleep off in 15 minutes can put a greyhound into a multi-day state of profound central nervous system depression.
That is wild. The pharmacokinetics completely fail. But looking through the genetic data in your notes, the mechanism behind the MDR1 mutation is even more alarming. We are talking about herding breeds collies, Australian shepherds, Shetland sheepdogs.
The multi-drug resistance 1 mutation, also known as the ABCB1 gene mutation, is a critical piece of knowledge. This gene is responsible for coding P-glycoprotein.
And P-glycoprotein acts as an active efflux pump at the blood-brain barrier. Its entire job is to recognize foreign substances or drugs that have crossed into the central nervous system and physically pump them back out into the systemic circulation to be metabolized.
Right. And when a patient is homozygous for the MDR1 mutation, those P-glycoprotein pumps are defective or completely absent.
Oh, no.
Yeah. The drugs cross the blood-brain barrier, achieve their intended effect, but then they are trapped. The brain cannot flush them out.
So they accumulate to highly toxic levels right within the central nervous system. The notes specifically flag common drugs here. Ivermectin, obviously, but crucially for anesthesia, but torphanol and azopromazine.
Yes.
If you give a standard pre-med dose of azopromazine and butorphanol to an MDR1 mutant collie, you're basically precipitating a profound neurological crisis characterized by severe, unremitting sedation and respiratory depression.
You are inducing an overdose directly in the brain tissue, regardless of the systemic blood plasma levels. This is why knowing the patient's genetic status prior to selecting your pre-medication protocol is absolutely vital.
And the specific physiological vulnerabilities don't stop there. Let's look at the cardiovascular anomalies noted for boxers.
Boxers have a well-documented idiosyncratic sensitivity to azopromazine. Even at microdoses, it can trigger unopposed vagal tone, leading to profound bradycardia and severe hypotension. But the greater concern is that boxers are heavily predisposed to arrhythmogenic right ventricular cardiomyopathy, or ARVC.
Their ventricular myocardium is essentially replaced by fatty or fibrofatty tissue, disrupting the electrical conduction pathways.
If you take a patient with an inherently unstable ventricular rhythm and administer an agent that drastically alters vascular resistance and drops their blood pressure, you are creating the perfect physiological storm for ventricular tachycardia and sudden cardiac arrest right on the table.
Moving from the electrical system to the hematological system, your notes highlight Dobermans. Their primary risk isn't necessarily clearing the drugs or maintaining a rhythm. It's a catastrophic failure of primary hemostasis. They are highly predisposed to von Willebrand disease.
Von Willebrand factor is an adhesive glycoprotein crucial for platelet plug formation at the site of endothelial injury. A deficiency basically means the platelets cannot adhere to the damaged blood vessel wall.
Which means you could perfectly execute the anesthetic protocol. But the moment the surgeon makes a routine abdominal incision, the patient suffers uncontrolled hemorrhage.
This dictates a mandatory presurgical assessment. You cannot proceed with a Doberman without performing a buccal mucosal bleeding time test to verify in vivo platelet function.
And you need plasma ready, right?
Yes, you must have cryoprecipitate or fresh frozen plasma readily available if the bleeding time is prolonged. And keep in mind, Dobermans also carry a staggering prevalence of dilated cardiomyopathy, further complicating their cardiovascular stability under volatile inhalants.
The cascading risks are just intense. The notes finish off this section with miniature schnauzers, specifically females, who are highly prone to sick sinus syndrome.
The sinoatrial node is the intrinsic pacemaker of the heart. In sick sinus syndrome, you have primary atrial node dysfunction. The heart simply cannot maintain normal sinus rhythm. It will present as severe bradycardia, prolonged sinus arrest, where the heart simply pauses for several seconds, or alternating periods of supraventricular tachycardia.
Given that almost all of our anesthetic agents cause some degree of dose-dependent cardiovascular depression, taking a patient with a failing intrinsic pacemaker and inducing narcosis is a massive vulnerability.
It is.
Continuous, real-time electrocardiogram monitoring isn't a suggestion for these dogs. It is the only way you will catch a fatal conduction block before it happens.
It demands an incredibly high level of clinical vigilance. You are simultaneously monitoring oxygen saturation, end-tidal carbon dioxide, arterial blood pressure, and electrical cardiac rhythms, all while filtering that data through the unique physiological and genetic limitations of the specific breed in front of you.
So as a veterinary student, just look at the complete picture your notes have painted today. You start with the absolute physiological requirements of the anesthesia triad, blocking the autonomic response with analgesia, securing unawareness through narcosis, and limiting reflexes with muscle relaxation.
You then deploy the pharmacodynamics of balanced anesthesia, utilizing multi-receptor targeting to lower the MAC of your inhalants and protect the cardiovascular system across the 4 distinct phases of the procedure.
And finally, you apply the critical thinking required in the danger zone. You adjust for the altered volume of distribution of the dolichocephalic sighthound. You anticipate the peak glycoprotein pump failure in the MDR1 mutant collie, and you prepare the fresh frozen plasma for the VWF deficient Doberman.
It is an incredibly demanding intellectual exercise. The fact that you are analyzing the precise mechanisms and pharmacokinetics rather than just memorizing dosage charts proves you are building the foundation of a truly exceptional clinician.
It's the kind of complex, mechanism-driven thinking that absolutely saves lives on the table. But before we wrap up this deep dive, I want to leave you with one final thought to mull over as you head back to the clinic.
Let's hear it.
We've seen how genetic variables like CYP450 deficiencies or ABCB1 mutations completely invalidate standard pharmacological math. Right now, pre-anesthetic blood work looking at liver and kidney function is the gold standard before a procedure. But as genomic sequencing becomes rapid and cost-effective, will the standard of care shift? Are we moving toward a future where a full genetic screening panel is a strict legal requirement before any veterinary patient is cleared for even a routine elective surgery?
Wow, that is a profound question regarding the future evolution of our preoperative protocols.
Something to consider the next time you review a patient's chart. Keep questioning the mechanisms, keep analyzing the data, and we will catch you on the next deep dive.